Thank you very much, Dr. Perales. Now we invite all the speakers and also the moderators and Hildegard Greinix to join the panel discussion. I would like to open this, we have some questions from the audience. I would like to open this discussion with the donors. And maybe this question to Feras. Do you think that this pandemic may change the way we choose the donors in situations with the patient that has not an HLA identical sibling? For example, when you have to choose between a MAD or a haplo, do you think that this pandemic may change the way we usually do this?
Thank you for the excellent question. Definitely, pandemic has changed. The COVID-19 pandemic has changed the world. I mean, probably forever in different things. When it comes to the donors, I do agree. First, it did accelerate the use of telemedicine. So it moved hospitals to go to the donors at home rather than the donors coming to the hospitals or donor centers. This is one. Two is the utilization of the donor sources. In the past, there was significant decline of using the umbilical cord, with more than 60% reduction in the last couple of years with the haplo. However, now the utilization of cord is climbing, as well as the haplo. So definitely, it did help in accelerating the use of different sources of stem cell products.
Thanks very much, Feras. And this question is for Dr. Huang. Is there any particular care that we have to take in the follow-up of the patients in this particular population? Dr. Huang, please open your mic.
It's okay. Do you have to hear my voice?
Yes.
Yeah. Okay, thank you. So in our sentence with more about the 70% of patients performs haplotransplantation and the last few years. So I think the haplotransplantation is more easy as contact the donor. And because the unrelated transplantation, we should be the transfer the stem cell from another city or another countries. I think it is very challenging, big challenge for such the pandemic area. So we suggest such the haplo donors and more easy for the unrelated transplantation. Another point we'd like to suggest is with the backup the stem cell in the liquid nitrogen, because with before the condition regimens, we will the storage of the stem cells in the liquid nitrogen. I think we can for the prepare for before the condition regimen for that. Yeah, thank you.
Thanks,
question
yes.
to, one question to Dr. Huang. Although you experienced just one case of unrelated transplant, you know, on those days, how did the China Maradona program work?
Please.
Can you hear me? Dr. Huang.
Yeah, okay. Yeah. Sorry, I haven't got your question. Please repeat.
How did the China Maradona program work on those days?
Yeah, okay, thank you. So the China's donor China's national donor registration is working on under the pandemic. So the different areas is because just like Wuhan, I think the severe condition the area. So for such areas, and we have to stop the new cases performed because it's the quarantine and the total quarantine, and know the plan and no chance and know the highways, the traffic. So another area is just like Hangzhou, we just stop about the 1 month because all the totally the quarantine. And after 1 month, we will go on the perform the unrelated transplantation. So we suggest the backup is the liquid nitrogen, the stem cell, and the backup is the haplo donors, and the sports as such as unrelated transplantation. So thank you.
We will move some questions from the audience. One is about the sensitivity of the COVID-19 PCR. Maybe for Clarisse. Clarisse, what would be in general the sensitivity of this method, and what aspects do we need to consider to increase the sensitivity when you check the patients or donors?
Well, I think that we have to pay attention. Well, when we test the patient, we have to be aware of the time from the beginning of the symptoms. If you test too early, maybe you have a false negative, or even if you test too late. So I think we should be aware of this. For PCR, the best is to test in the first week, but at least after 4 days of symptoms, for instance. And for serology, it's best increase positivity after the 14 days. So the second week of the symptoms is the best to start testing for antibodies. So it depends, the sensitivity varies according to the time you test. So if you test the right time, probably you have more than 70–80% of sensitivity for PCR and more than 90% sensitivity for serology, for both a donor or recipients or whatever.
Thanks, Clarisse. Another question is, if a donor reports symptoms days after donation, can we perform PCR in the product, or should we exclude immediately the product for donation? It's more clinical, but what do you think, for example, Dr. Perales or Per Ljungman, what do you think about this?
I mean, this is Miguel Perales here. I think currently the recommendations regarding the collection of a positive donor is to defer. If the donor appears to be positive after collection, there is currently no documentation of transmission through a cell product or even through a transfusion. So I think you have to weigh the risks and benefits to the patient. If the donor is now positive, you would have to wait several weeks to collect them, and you may not have an alternative donor. So I think in this circumstance, you would have to really determine what the potential risk benefit to the patient is. I think most of us think that there's a low likelihood of transmission through the product itself, since this is a respiratory virus, but we cannot exclude it.
I would completely agree with that. Respiratory virus is attached to receptors in the airways. The likelihood that you should be able to get a persistent infection by probably quite low viral load of an RNA respiratory virus in blood, that's highly unlikely. You know, we have a lot of experience with other respiratory viruses that this doesn't happen. So I think that it cannot be 100% excluded, but the risk must be very, very low.
I would like to ask a question for Clarisse also, because there are other respiratory viruses. She has worked a lot on it. What can you tell us about the screening for other respiratory viruses?
Well, this is one of the recommendations to screen patients before transplantation for other respiratory viruses, even those who are asymptomatic. But this recommendation is not there is no compliance to this recommendation, even because some centers they don't pay, the health insurance don't pay for tests in asymptomatic patients. So, but we have tested, we have screened the patients before, and we have found around 18–20% of positivity for other respiratory virus in stem cell transplant candidates. So mainly rhinovirus, and the second one is coronavirus, the good ones. So I think we will change our mind concerning after this pandemic, respiratory virus will be back to the main stage, and I think we will think better about them before transplantation.
Thanks, Clarisse. I will ask a last question, and then I will give to Hildegard, that has another question from the audience. The question is, when we cryopreserve cells for allogeneic patients, how many days we should wait to make sure that the donor is negative for COVID-19? I don't know, maybe Feras or Per can ask this question.
I think, I think the answer will come down to the risk for whom. You have to take into account the potential risk for the donor to undergo a procedure very soon after a COVID infection. Couldn't that, we'd heard about from on the CAR T cells about G-CSF. You are stimulating with G-CSF. Can that be harmful soon after a COVID infection? That's at least theoretically possible. The other risk is what we just discussed about the patient. I think the risk for the patient is very, very low. But I think but donor safety is paramount, and that has to be taken into account first.
Thanks, Per. Please, Hildegard, you have a question for the speakers, and also Dr. Codera.
Thank you, Sebastian. My question is about antibody testing in hematologic patients. So, of course, it's not a surprise if patients are after chemotherapy and rituximab that they're not able to mount an antibody response. But we had one patient 6 weeks after allogeneic stem cell transplantation who was on a COVID ward, and they, on a routine basis, did antibody testing, and she was IgG positive. So I was wondering whether this was from transfusions from before cross-reactive to other coronaviruses?
I think that's an interesting question. I have a case which is similar. I have a patient of mine who underwent an allogeneic transplant about 60 days ago. She became COVID-19 infected shortly after her discharge from the hospital. At the time, we checked her immune panel, and she had 0 B cells. She actually wasn't very symptomatic. She's persistently COVID-19 positive on swab. She's had no symptoms really, other than a mild cough. We've checked her serology, and she's using the Abbott test. She's positive by IgG for COVID-19. And I rechecked her B cells yesterday, and she has 0 B cells using a sophisticated 8-color flow panel, and she has very little T cells, including helper T cells. So how do you explain that? The ability to mount antibodies in the absence of peripheral B cells at 60 days post-transplant on immune suppression with tacrolimus. I think there's a lot that we don't yet understand about this, and maybe Per can answer some more. But the common practice to wait a year for vaccines, obviously in the setting when acute infection, patients can mount an immune response.
I think your question, is it cross-reacting, theoretically positive? Is it passively transfused antibodies for blood products, theoretically possible? Could it be from the donor, theoretically possible? all these things are possible. Which one is true, I don't think we can really understand from what story. We know if you go back, and this is mainly pediatric patients, but there were some interesting data by Jack Fossen very early looking in that if you immunize with tetanus, maybe 4, 5, 6 weeks after transplant, you get an immune response. But if you wait, you don't. So you have an early transfer of donor cells that might respond even if you don't have a lot of circulating B cells. Clarisse and I did together a study on flu vaccine where we tried to immunize donor and patient and so on. And the lesson of that was that we probably waited too long after transplant to vaccinate the patient. So all these things are theoretically possible, but I would probably go for a false positive result as the most likely scenario.
Yeah, I think the point you bring up is very interesting. There's, you would probably recall the paper by Rappaport and Carl June, where they did adaptive transfer early after auto transplant and looked at responses to pneumococcal vaccine and showed that patients who had been vaccinated before, leukapheresis, and then had early T-cell infusion with vaccination had an enhanced response. The idea being that if you immunize during the homeostatic proliferation in the lymphopenic patient, you get enhanced responses. And I had published papers also doing a similar work in preclinical mouse models. There really is a window where you can get these marked vaccine responses, but if you wait too long, you lose that window. And maybe
Jan Storek did a controlled trial also several years ago into the donor and recipient vaccination and so on. So I think this is clearly possible, but we also don't know enough about COVID serology, how that actually works with all these different tests and scenarios.
Great discussion. And another question from the audience, because we have the last minutes. Yes, Dr. Codera, go ahead.
Question to Professor Ljungman. You have collected more than 200 transplant recipients who are suffered from the COVID-19. May I know the duration of the time from the transplantation?
Yeah, it's a median in the allos about 10 months. So but this goes all the way. We actually have patients that were COVID positive during conditioning. So it's actually even a couple of patients we have minus days, and it goes all the way out to 20 years. So it's a very wide range. When we will go in and we will look at ongoing immunosuppression, pre-COVID pulmonary morbidity, and a lot of those things. We don't have that data yet. The way it happened in Europe is that we have a lot of patients included in the study from the last days of March and up until Easter or so. And those have too short follow-up to really do a careful analysis. The question is very logical, and I got it a lot, but I don't know yet.
Yeah, thank you.
I think we all look forward to seeing your data.
There are some questions regarding the active treatment against COVID in transplant patients. For example, antivirals or anti-inflammatory drugs such as chloroquine or tocilizumab. Do you have any data on this?
I think maybe Memorial has some data on the local patients. Our own patients in Stockholm, which are we have about 10. We have treated one of them with chloroquine. The other ones have so far been untreated. And most have done well, both adults and children. But there are a lot of clinical trials ongoing, and data is coming out more or less every week. would we expect that the transplant patients would react differently to these drugs than other people? Well, certainly chloroquine with a lot of the drugs we are using can have interactions. That's one problem. Many of these patients are probably already on steroids, which takes care of the anti-inflammatory thing. So I think we need more data to know.
Thanks very much. I think we have to close the session because we are on time. As usually, we would like to have more time for the panel discussion. That's something we are going to think in the future. I would like to thank Martin from the WBMT office and the Saudi Society for Blood Disorders, particularly NADA from the society, for the help in organizing this committee. I will pass the microphone to Dr. Codera to close the session. Dr. Codera is past president of WBMT and he's the co-chair of the education committee. So Dr. Codera, please.
Oh, anyhow, thank you for your participation. It is a very great pleasure for me to chair this exciting webinar, which is organized of WBMT. I hope this would be a good model of our conference in the future. And I express my thanks to Sebastian, who mostly organized this nice webinar for very much. Thank you for your attention.
Thank you, everybody.
Thank you.
Thank you.
Thank you.
Thank you.
Thanks.
Thank you very much to all the speakers. Thanks and bye.
Bye-bye.